Hello everyone, and I hope all my students are doing really well. So today, this is just an addition to my ongoing lectures. So what I thought, as I published more than 80 papers in various national and international journal, so what I thought that I would discuss a few cases in between my lectures. So this will be helpful to our postgraduate students in pathology and various other clinical subject also. So this is basically to tell you tell you basic things, that how you approach to certain case, how you find how you finally arrive at a diagnosis. So this is basically a clinico-pathological integration in each case, which you will see that I'll be discussing. So see, today I'll be discussing, so let's take it as case number 1. So this is cytodiagnosis of EMH. Cytodiagnosis means the diagnosis was made on basis of cytology, followed by other confirmatory test. EMH is extramedullary hematopoiesis. So EMH, normally hematopoiesis के sites होते हैं हमारे, ठीक है, which varies according to the age. So adult में कहाँ पे होता है, ठीक है? So you have your where the like normal in bone marrow the hematopoiesis is there, fine. So but if you get hematopoietic cells apart from your marrow, okay, then like at different sites, suppose you get in liver, you get in spleens, which is not according to the age. So here we got in thyroid gland, so that I'll be discussing in detail. So getting these EMH, extramedullary hematopoietic cells, in thyroid, it led to a diagnosis of an underlying hematological malignancy. So let's proceed to this case. So see, just basic introduction, what is EMH? As I told you, it is extramedullary hematopoiesis. It is also known as myeloid metaplasia, and you can see EMH in association with various hematological disorders. So see, common site of EMH क्या होता है? See, normally hematopoiesis occurs in your bone marrow, but if you get extramedullary hematopoiesis, the common sites are liver, spleen, lymph nodes, but you can see it in any other organs also. So involvement of thyroid gland in EMH has rarely been reported. So what we are going to discuss in this case is about an adult female who was diagnosed on basis of fine needle aspiration cytology, that you commonly know as FNAC. So which further helped in revealing an underlying myeloproliferative neoplasm, that is chronic myeloid leukemia. So let's see how it was diagnosed. So a 45. So this is the basically when a patient comes to you for FNA. So see, it's not just you blindly need to put a needle and you see the smear. We have to correlate with the clinical findings. So clinical detail, taking clinical detail is very important. So she was a 45-year female. She presented to hospital with following chief complaint. So we need to know the detailed clinical complaint of the patient. So she had swelling in the neck for past 1 year. She had mild sore throat, decreased appetite for last 2 months. So these are the clinical complaints for which she came to hospital. And she also told that swelling had progressively increased in size in the past 2 to 3 months. So on examination, what we noted, there was a diffuse swelling which was present in the neck involving the thyroid gland, which measured approximately 5 into 4.5 centimeter. Then swelling was seen, how the extension of the swelling, if we noted, it was seen extending from the right sternocleidomastoid 2.5 centimeter away from the midline of the neck. So towards the right side. It was, so when you explain a swelling, when you have explained the size, then extension, so how you, when you palpate it, so how it was non-tender, form in consistency, and it moved with deglutition, so means thyroid swelling. Fine. So see, there was no sinus or any fistula, so you did not see any fistulas opening or tract inside the above the swelling. No redness, or when you see this is how you describe a proper swelling. So no evidence of any redness or any visible palpation, okay, and no palpable lymph node was identified. Why we examine lymph node? To see whether it was any, if any malignancy is there. So we need, if any lymph nodes are there, so we need to examine all properly. And she also gave a history that she had undergone eye surgery for cataract 2 years back. But see, we need to take history in detail, maybe any association. So general and systemic examination also was done, did not reveal any abnormalities. See, so these point is very important. So coming to cytological findings, see, when we did the FNA, so after FNA, see what we do, we study the smear under microscope. So what we got sheets and clusters of benign follicular epithelial cells with chunks of colloid. I'll show you the clinical and the cyto pictures. So उसमें हमें मिला शीट ऑफ थायराइड स्वेलिंग से हमने एफएनए की, उसमें हमें बिनाइन फॉलिकुलर एपिथेलियल सेल्स मिले जो कि नॉर्मल है थायराइड ग्लैंड में, एंड चंक्स ऑफ कोलॉइड. बट बैकग्राउंड में हमें क्या मिला? It was not just the benign follicular epithelial cells which steal the show. Here the important thing was the presence of numerous hematopoietic cells. Normally जब हम thyroid में expect नहीं करेंगे कि हमें myeloid series के cells in different stages of maturation मिले, जैसे myelocyte, promyelocytes, ठीक है, ये सब चीजें नहीं मिलनी चाहिए हमें. ग्रुप ऑफ एरिथ्रॉइड सेल्स, एरिथ्रॉइड आइलैंड्स में सेल्स थे, और इवन वी गॉट मेगाकैरियोसाइट्स, फाइन, which was singly scattered, hyperlobated and hypolobated. So hyperlobated and hypolobated, this is how we describe megakaryocytes. So with this FNA material, we even made a cell block to see what was the tissue pattern, fine, and for which we stained it with H&E stain. And the section examined showed evidence of extramedullary hematopoiesis. So on basis of cytomorphology and histological examination, which we did through the cell block, we made a diagnosis of extramedullary hematopoiesis, which was involving the thyroid gland. Fine. So see, this is the image. Figure A में क्या देख रहे हैं हम? This is a swelling which is more towards the right. In detail explanation में also I told you that it was from the right sternocleidomastoid 2.5 centimeter away from the midline. So in figure B, what we are seeing is group of follicular epithelial cells, benign follicular epithelial cells. C, we are seeing chunk of colloid material. So it like a thyroid gland की जो भी abnormality है, that is purely benign, fine. But D, you see in D and E and F, I am telling you, D में आप देख रहे हो जो dark cells हैं, so those are your erythroid island with the dark nuclei, and the lighter nuclei which are bigger, so those are the myeloid series cells. E, we can see proper myeloid series cells. आपको neutrophils भी दिख रहे हैं, myelocytes भी दिख रहे हैं, band forms भी दिख रहे हैं, ठीक है. And this is actually a picture of a particular area, but in the whole smear we saw like evidence of myeloid cells, erythroid islands, and F, we can see these are hypolobated megakaryocytes. So when we get this, all the three elements of hematopoietic cells, so we confirm that the diagnosis was EMH. तो ये जो हमने सेल ब्लॉक बनाया था FNAC के मटेरियल से, सो A में आप फिगर A में देखो क्या है, दिस इज अ फॉलिकुलर एपिथेलियल सेल्स. So it's just like cell block के advantage होते हैं ये. So we can get a tissue architecture to study with the cytological material. Fine. So what we can get here, what we are seeing here is thyroid follicular cells. और बीच में आप देखोगे जो क्या है colloid. So B figure में देखो, this is purely, this is a ये ऐसा लग रहा है जैसे we are studying a bone marrow biopsy. Here we can see myeloid cells, erythroid cells, and megakaryocytes. So this is from the cell block which was prepared from the FNAC material. So we'll not end here that we have made a diagnosis of EMH, but we need to find the clue why EMH is there in thyroid when it is not normal to find EMH in thyroid. So we further investigated the patient with peripheral blood, CBC करवाया हमने उस patient का, and what you know, hemoglobin was 13.9, but the 45-year-old female, she had marked leukocytosis, leukocyte count being 98,000 per microliter. Platelet was normal. So hemoglobin and platelet were normal, but patient had marked leukocytosis with TLC 98,000 per microliter. Peripheral smear जब हमने देखा, उसमें भी marked leukocytosis, and what we saw was presence of immature cells of myeloid series with myelocytic bulge. So RBC were normocytic, normochromic, and platelets were adequate. So no abnormality in RBC and platelet series. So it was only the TLC or the TLC which we have to look and investigate properly. Few nucleated RBCs were present. Patient's liver and renal function tests were within normal limit. So see, this is the peripheral smear. Normal TLC count कितना होता है? 4,000 to 11,000 per microliter, but इसमें 98,000 per microliter. ठीक है, and with presence of immature माइलॉइड सेल्स, देखो माइलोसाइट्स, ये नॉर्मली अगर आपके टीएलसी बड़े होते तो क्या दिखेगा, या तो आपके पॉलीमॉर्फ्स बड़े होंगे या लिम्फोसाइट्स बड़े होंगे, बट इमेच्योर फॉर्म्स पेरिफेरल स्मीयर में आना इज नॉट नॉर्मल थिंग. सो दिस ऑल्सो यू सी इन योर बोन मैरो, नॉट इन पेरिफेरल स्मीयर. फाइन. सो जब हमने रेडियोलॉजी करी उस पेशेंट की, सीईसीटी पे CCT neck was done, which showed an asymmetrical enlargement of the right lobe of thyroid and part of isthmus, so which very much correlates with the clinical examination. Fine. And see, no calcification was noted in CECT. And left side deviation of trachea hogi, obviously because of the compression effect, which is caused by the enlarged right lobe of thyroid. So your trachea is pushed towards left. But CECT में, so point which I was stressing upon was general and systemic examination was normal in this patient. No calcification was noted in CECT in spite of being evidence of EMH in thyroid gland. So correlate the things. And even we did the bone marrow examination for this. So patient को CML तो है, ठीक है, chronic myeloid leukemia है, which stage and all thing that we need to confirm further. So bone marrow smear जब हमने patient का bone marrow किया anterior superior iliac spine से aspirate निकाला, so what we got was the marrow was markedly cellular with myeloid erythroid ratio being 13:1. So there was marked increase in myeloid cells, which and the cells were in different stages of maturation. So obviously जब there is when एक series की cells बढ़ती है, तो what we see, the other cell line is suppressed. So here you see erythropoiesis was relatively suppressed. Relative word हम use करते हैं in comparison. When once एक series की cell बढ़ेगी तो obviously दूसरे series की cell down हो जाएगी. ठीक है, so erythropoiesis was relatively suppressed, showing mixed reaction. So patient both normoblasts and megaloblasts थे हमारे. Megakaryocytes were adequate and functional. Few showed dysmegakaryopoiesis. क्या होती है? Structural abnormality, कुछ hypolobated, hyperlobated, ये सबको हम कहते हैं dysmegakaryopoiesis. Bone marrow biopsy, it very much correlated with the bone marrow aspirate findings. ठीक है, just few scattered histiocytes were seen and no fibrosis and no blast cells were seen. Blast cells हम detect करते हैं CD34 से. ठीक है, साइटोकेमिस्ट्री हमने किया, लैब स्कोर जो हमने ल्यूकोसाइट अल्कलाइन फॉस्फेटेज स्कोर वाज फाउंड टू बी डिक्रीज्ड. ठीक है, नॉर्मल होता है 35 to 100, इस केस में था 24. तो दिस इज कंसिस्टेंट विद CML. तो CML में हम ये स्टेन करते हैं, स्पेशल स्टेन. ठीक है, सो आर पेरिफेरल स्मीयर फाइंडिंग, जो CBC में काउंट मिले थे हमें 98,000 per microliter, presence of immature myeloid cells in peripheral blood smear, that finding, and bone marrow evidence in cyto, bone marrow aspirate and bone marrow biopsy all confirm the diagnosis of myeloproliferative disorder. अभी भी हम इसको MPN कहते हैं. MPN के अंदर बहुत सारे आते हैं, हमारे 4 एंटिटीज हैं. ठीक है, जैसे आपका ET होता है, प्राइमरी माइलोफाइब्रोसिस होती है. ठीक है, सो ऑल दीज ऑल कम अंडर योर myeloproliferative disorder. So CML is common one in this. So see, this is the image. ये हमारा पेरिफेरल स्मीयर फाइंडिंग था A, जिसमें हमें माइलॉइड सीरीज के सेल्स विद इमेच्योर फॉर्म्स मोर ज्यादा मिले थे. B यू कैन सी बोन मैरो एस्पिरेट है, जिसमें कि मार्क्ड सेलुलरिटी है, माइलॉइड्स बड़े होते थे, हमारे मेगाकैरियोसाइट्स भी बड़े हैं. दिस इज द हाई पार. एंड D इज शोइंग यू द सेक्शन, बोन मैरो बायोप्सी के सेक्शंस है, जिसमें बड़े बड़े जो सेल्स हैं वो हमारे मेगाकैरियोसाइट्स है. एंड देन वी कैन सी न्यूट्रोफिल्स एंड ऑल द माइलॉइड सीरीज सेल्स इन डिफरेंट स्टेजेस ऑफ मैचुरेशन. So these are the example of images of your peripheral smear, bone marrow aspirate B and C. D is showing your bone marrow biopsy. So these all confirm the diagnosis of myeloproliferative neoplasm. And हमारा जो lab score था वो भी favor कर रहा था CML को. CML में lab score decrease हो जाता है. ठीक है, so this is what अभी तक हमें क्या मिला diagnosis. So हमें clinico-radiological evidence से cytomorphological, histological findings and peripheral blood along with bone marrow examination, including in immunohistochemistry. So we did all this for this patient, and finally we arrived at a diagnosis of EMH in thyroid gland with underlying myeloproliferative neoplasm, that is chronic myeloid leukemia. Blast cells increase nahi ho rahe, which we got from CD34. CD34 was almost negative. So उसमें क्या मिला हमें कि this is in your chronic phase. CML is in chronic phase. जब blast cells बढ़ जाते हैं बहुत ज्यादा तो acute phase हो जाता है. ठीक है, blastic phase भी हम उसको कहते हैं. फिर हमने इसका molecular finding किया हमने इसका BCR ABL in the peripheral blood So that supported the diagnosis of, इसमें Philadelphia chromosome positive आया था हमारा BCR-ABL gene. So that confirmed the diagnosis of chronic myeloid leukemia. So this patient therapy में most important drug क्या है? Patient का था imatinib mesylate drug therapy was given to the patient, and in fact till date also the patient is under clinical follow-up and she is doing perfectly fine. And you know what? Her count after this imatinib mesylate therapy, her count decreased from 98,000 to 6,000. Okay, after this therapy. So EMH is seen in association with many clinical conditions. आपको extramedullary hematopoiesis मिलेगा in association with chronic anemia. It can be seen in anywhere, liver में, spleen में, जो भी हमने sites बताई थी EMH की वहाँ मिल सकता है. Thalassemia, spherocytosis, many hematological malignancies like myelofibrosis, leukemia, etc. And sometimes it can be an incidental finding as we noted in our case. सोचो patient आया था thyroid examination के लिए to hospital, and but after investigation FNA thyroid पे we got EMH, retrospective कराया, CBC में बढ़ा हुआ, peripheral smear, bone marrow examination, molecular studies, everything was confirmed. Patient was diagnosed with CML and then she was put on therapy and she recovered so well. ठीक है. So presence of, so important thing based on cytology क्या है? अगर हमें मेगाकैरियोसाइट्स मिल जाते हैं, so that is a cytologic signature of extramedullary hematopoiesis, क्योंकि वो बड़े बड़े सेल्स होते हैं and can be readily recognized in a cytological smear. ठीक है. But जब presence of these megakaryocytes, suppose thyroid FNA हम कर रहे हैं, ठीक है, so we need to know the differential diagnosis when we get these kind of big cells. इस केस में तो हमें तीनों एलिमेंट्स मिल गए, ठीक है, एरिथ्रॉइड, माइलॉइड, मेगाकैरियोसाइट, सो इजीली हमने कह दिया कि ये EMH है. ठीक है. बट अगर सिर्फ मेगाकैरियोसाइट्स मिले, दैट इज आल्सो साइटोलॉजिकल सिग्नेचर, हम उसको बोलना ही पड़ेगा हमें EMH. बट उस केस में आपको डिफरेंशियल डायग्नोसिस, यू हैव टू रूल आउट द अदर कॉजेज ऑफ प्राइमरी थायराइड, क्योंकि एनाप्लास्टिक कार्सिनोमा ऑफ थायराइड में भी ऐसे बड़े बड़े सेल्स मिल सकते हैं, तो हमें उन सेल्स को डिफरेंशिएट करना होगा फ्रॉम मेगाकैरियोसाइट्स. ठीक है. बट हमारे लिए इजी हो गया बिकॉज वी गॉट other hematopoietic elements like myeloid cells, erythroid cells, along with those megakaryocytes, and also what we got were benign follicular cells के cluster with specks of colloid. So in our case it ruled out any possibility of malignancy in thyroid gland. See, this case is very rare. ठीक है. Previously thyroid EMH has not been associated with chronic myeloid leukemia. ठीक है. Our case is much, I'll tell you in brief the review of literature also. हमारा केस बहुत रेयर था because in having extramedullary hematopoiesis in thyroid gland, that is per se it's rare. ठीक है. Second point, it did not have calcification. मैंने कहा था CECT neck पे no evidence of calcification in spite of having EMH. Then patient को हमने diagnose किया chronic myeloid leukemia. ठीक है. This has not been yet been reported. So this was the first case to be reported in literature. Okay, in association with EMH, thyroid EMH. So see, this was a review. So this case was actually, we reported in 2019 when I was doing my senior residency in Ramanollaya Hospital, New Delhi. So that time we had reported this case. Okay. So see, this was a review of literature for evidence of thyroid EMH. So this was thyroid EMH के जितने भी केसेस थे वो हमने रिव्यू ऑफ लिटरेचर में देखे. सब में हमने देखा कि जो डिजीज एसोसिएटेड था या तो मल्टीनोडुलर गॉइटर था, माइलोफाइब्रोसिस, क्रॉनिक अनीमिया, डायबिटीज, मल्टीनोडुलर गॉइटर. नन ऑफ द पेशेंट हैड क्रॉनिक माइलॉइड ल्यूकेमिया इन थायराइड EMH. ठीक है. So when we reported this case when we published this paper, so that time 27 cases of thyroid EMH were reported, but in association with CML was our first case. So to conclude, the present case study, this case report highlights the importance of a simple investigation. सोचो आप, एक FNAC से you can diagnose a rare case in thyroid EMH, which further helped in detection of MPN in patient. So the rare finding noted in our case were thyroid EMH without calcification, and also see CML जब आप पढ़ोगे ना, organomegaly is a very important feature. So splenomegaly, hepatosplenomegaly is very common in CML. Here in this patient after systemic examination nothing, no abnormality was detected. ठीक है. बहुत सारे rare points थे इस केस में. So these were our few reference, and see, we got this case report published in a very esteemed journal of cytojournal, that is diagnostic cytopathology. It's a very reputed international journal, and this case I got it published under guidance of Dr. Manju Kaushal. She was my professor and head of the department of cytopathology in RML hospital. This was a very rare case. So basic idea behind like describing these kind of cases is that when you approach or when you're posted in FNA, especially for the MD pathology student, when you go for doing any FNA, so keep your mind open. Like when it's not just about we have to study the slide and we have to give the report. It's a clinico-pathological approach when you see a patient or when you do FNAC of a patient. So you need to correlate many things. Okay? Proper clinical history लो, प्रॉपर रेडियोलॉजी आपको डेटा रेडियोलॉजी एविडेंस होनी चाहिए आपके पास. देन यू कैन सी व्हाट यू सी व्हाट यू सी इट्स ऑलरेडी इन योर माइंड. सी जब आपने पढ़ा है वही आप देखोगे एग्जैक्टली. ठीक है, रैंडमली हम कुछ भी देख के कोई डायग्नोसिस नहीं बना सकते. ठीक है, सो ऑलवेज कीप अ इंटीग्रेटेड अप्रोच, discuss interdepartmental with your interdepartmental colleagues, and then arrive at a final diagnosis. So that helps in getting arriving at a diagnosis. So never, always think of common diagnosis first, then अगर आप उसको rule out करते जाओगे, then we can arrive at the final rare diagnosis also. Okay, thank you so much.